And we'll try to see if we can finish up our next two introduction pieces in the next 15 minutes and then really open the floor up for all of you. So it's my privilege to introduce Dr. Dan Wikler. And Dr. Wikler is the Mary B. Self-Installed Professor of Population Ethics here at the School of Public Health. And has a rather distinguished career in a leadership role in ethics in the World Health Organization. And he's created the Harvard Program in Ethics and Health. He's also the co-founder and second president of the International Association of Bioethics. So, without further ado.
Thank you. Let me begin by a little homage to two of the other symposias. Mary knows light, that's very useful. But having worked with Luke and with Frank, not all of you have, so it might be useful to mention something about them. The WHO is a pretty timid outfit. It's owned by its member states and doesn't like to get out in front. The worst case of this on record, according to legend, was when Jonathan Mann, who was an infectious disease specialist, went into the Director General's office and said, "Sir, there's this new disease called AIDS, and it looks pretty serious, and although no one's ever heard of it, if we get in there, we can try to contain this thing, but if we don't, it could become a terrible pandemic." And the response was, "Well, we're not hearing a lot about this from the member states, so your request is denied," and the result is history. Now, and this happens a lot at WHO because the boss are the member states, and they call the tune. Luke is one of the relatively few people there who has a clear vision of what should happen and who just goes out and makes things change. And I've seen over these several years that he's been working on this tireless activity in all parts of the world, where he's able to go to a region or a country where the trend is toward legalizing what's being called trafficking. And when he comes away, there's been progress, and it's really quite marvelous to see. So a tribute to Luke, who is really a credit to the organization. Now, Frank, as we know from these publications that were flashed on the screen here, is among either the world leader or certainly one of the handful of world leaders in shaping opinion on this subject. And I think Frank has performed beautifully on this in many roles, but I think the high point, at least in my experience, was at the negotiations in Istanbul that resulted in that declaration. This was a joint meeting of the transplant and nephrology specialty societies from around the world. Quite a diversity of opinion. They invited a lot of dissenters, people, libertarians and others, who basically thought the organ trade was a great idea. Frank was in the middle of a very large ring. It must have been 100 people. And wheeled and turned around, spun and included and cajoled, and for 2 solid days on his feet did one of the most remarkable performances I've ever seen, and came up with almost unanimous support for this rather tough declaration. So I'm not sure I knew anybody else who could have done that. Now, I'm a philosopher just like Mary is, so I get to take some steps back, and what I'd like to do is to make 3 prefatory remarks. It's a little bit off subject, if I can have your patience for just a moment, but I think it's useful to keep 3 things in mind as we talk about this topic. First one is that the question of kidney transplantation, which is the main thing we're talking about, can be embedded in a larger issue about what the world should do about end-stage renal disease. What happens if your kidneys shut down? It's one solution to that problem. You get a new kidney. The other solution is dialysis. Now, in the United States, dialysis is not much discussed as an issue because it is the single disease that's got its own law bestowing an entitlement on every citizen in the United States. If you have end-stage renal disease, you get dialyzed, which has been a golden profit opportunity for the people who supply that service. But the rest of the world has not followed suit, and in the developing world, both poor countries and the lower tier of the middle-income countries, it's a big, festering social problem. Dialysis remains expensive, and no one has figured out a way to drive the cost down very much. And basically, in terms of its limited cost effectiveness, they can't afford to give it to everybody. But there's intense pressure because without it, you just die. I don't see my colleague Dan Brock here. Dan has the chair in ethics at the medical school. He and I and some others from around the world have been working on a project with the government of Thailand for several years now on their dilemma with respect to dialysis. They cannot seem to get the kidney donation rate up very much. So only 5% of the problem is taken care of by transplant. 95% is left to dialysis. And they cannot afford it. It would be wrong for them to get to everybody who needs it. They have to select. And the question is how to choose. You, sir, will live, and you, sir, should prepare to die. It's a problem facing all these countries, and the big one now is going to be China as they try to institute a national health insurance scheme. So there's a larger subject of which this overlaps quite a bit. Second big background remark is that I think it's useful to reflect for a moment, even though we take transplantation for granted, how recent this is as a development. But the second thing is a peculiar effect that it had on the bodies of the poor. In the advanced countries and South Africa, the advanced part of South Africa, transplantation is developed, wonderful. People can live now who would have been goners just a few years ago. Just because of that development, poor people in remote parts of the world have two diamonds, a diamond on each hip. They have an asset now that's worth a lot of money to somebody who's got money and who will die or face inadequate quality of life through dialysis unless they can get a hold of that organ. Now, they didn't have this asset before, but suddenly their bodies are worth a lot of money. Given the tremendous imbalance or inequality in wealth between the richest countries and the poor, I've just spelled this out. This creates a new situation, a new bunch of dilemmas, and I think that's part of why we're here today is talking about this. So something that happened in a faraway land, the development of kidney transplantation, suddenly creates a situation where formerly destitute people whose bodies might have been worth very, very little as day laborers are now worth a whole lot of money as long as they're willing to give up one of those organs. And if it's not worth it to them, then it's worth it to somebody else if they can get those organs out of them. And there's no way that's going to go away. If anything, it's going to increase. Now, the third thing to say, I think, is that if we think that there's a problem with the trafficking in organs, so that there should be some kind of clampdown, this doesn't happen as much, or maybe it shouldn't happen at all, you better have a good argument for it. Because there's an extremely good argument for allowing it. And the good argument for allowing it is that it saves lives. People go hunting for organs because they're about to die. Or in some cases, because they don't want to face dialysis. But that's often tantamount to the same thing. So, on the one hand, you've got willing seller, in many cases, extremely eager buyer, much more money in the pockets of the buyer than the seller would ask for if they were selling to a peer. That looks like a recipe for a win-win situation if ever there was one. And to say no is to say that these people who want to buy should die. We better have a very good argument if we want to say no. Now, actually, I'm on the side of those who say no. I wish I had better arguments, but what I want to acknowledge is we need a really good one. Now, let me give a quick sketch of what I think the arguments look like. And I'm not going to go into detail on any of them, but I think it's useful to keep them apart as we think through this. Mary's, I think a lot of the thrust of Mary's talk is that to use this word trafficking in a way is to threaten to beg the argument. It's a beg the question. If you can get the issue to be should we be trafficking in organs or not, you've won. Everyone's opposed to trafficking. It's a word that basically connotes disapproval. So is it fair to start off on the premise that if there's trade, that constitutes trafficking? Which, looking at certain clauses as Mary just did, does suggest this. Well, if that's so, then we've gone too fast because, of course, the argument is going to be, has to be, whether the trade is wrong. Now, it's easy to focus on the role of the third parties, the brokers, for example, maybe the clinics. Because if there's going to be something that's akin to slavery, the model we have to have in our mind is there's an enslaver, and maybe someone who owns a slave or controls the slave. And I think in some cases it's quite appropriate to do that, and I'll mention a case in just a moment. But the core issue about whether rich people or people who live in rich countries should be at liberty to fly to excellent clinics in very poor countries and accept an organ from a very, very poor person from that country and go home much healthier. That's the basic issue, even if there's no broker. If magically the rich person could fly in, meet a seller in a marketplace, and just swap some body parts, the issue would still be there. Most of the issues we deeply care about, I think. So, although for the purposes of squeezing this into the trafficking definitions, the third parties are very important. I think the core issue is one that remains even if the trafficker's role is really not what we're focusing on. So, I think broadly speaking, there are two kinds of arguments for curbing the trade in organs. And the second has three variations, so excuse me for all this complexity. The first kind basically says this: there may not be anything inherently wrong with the idea of an organ trade, of a market for organs. But there are certainly there's something wrong with abuses, and if we allow a market for organs, the abuses are inevitable, and that's why we have to make sure that there are no markets for organs. So again, it says there's nothing inherently wrong with it, but if we have it, either we won't be able to prevent the abuses or it will inexorably slide toward a situation where abuses are rife, and that's why we have to stop it. Now, we don't have to look very far for abuses. Luke mentioned the research done by people at the Sindh Institute in Karachi on what the fate of the people who actually sold the organs, and it's not pretty. Those same researchers, in some unpublished work, have found out why these people got to be sellers in the first place. And when you hear the stories, it is remarkably akin to slavery. These are day laborers who, like, I come from Kentucky, so I know about going to the company store. I can talk about Ph.D. The day laborers in these villages in Pakistan rent their land that they plow from the rich landlord, and they buy all their supplies from the store that's set up by the rich landlord. Now, the rich landlord hears that there's a lot of money in selling kidneys to rich foreigners who fly into these clinics that Luke found on the web. So all they do is they raise the rent, they raise the prices, and pretty soon they don't raise the wages. So pretty soon these guys are behind, and then they're further behind. And now the landlord says, you're not up on your rent, and also they're buying less and less food, their kids are hungry, and the landlord starts saying, if you don't keep up in your rent, I'm just going to have to let you go and get somebody in here who will work hard enough to be able to pay the rent, and there's nowhere for them to go. And then finally the landlord calls them in and says, there's one thing you can do to make all this go away. And soon the broker and the laborer are huddled in negotiations. And one of them is less a kidney within a couple of weeks. Now that's pretty much like slavery. And it's, again, this consequence of this technological breakthrough in the surgical field, putting diamonds on the hips of the very poor, and someone's going after it. Now, if we want to say that what's wrong with the trade in organs is that this will happen, it's an argument worth taking into account. Of course, the question is it inevitable, and is the price too high when the number of cases that would happen? So these are questions of numbers and law enforcement and so on, which I won't go on about. Now, the second kind of argument is one that says, no, it's not that we need to ban it because there are abuses. It's because it's inherently wrong. Of course, the question is, well, what's inherently wrong about this trade? And here are three variations. First one uses the word commodification, very common word these days, to sell any part of the body is to treat it like a commodity, which it isn't. And depends on your account, but it's a quick jump from there to the conclusion that it's wrong. I'm not persuaded by this. My colleague Dan Brock has had his kidney for sale for several years now, after following a meeting with Luke and Frank at the WHO. He's 70 years old and has a serious disease, I have to tell you, but he is willing to sell one of his kidneys for $2 million. So would there be something wrong with his doing that? Something deeply immoral? Would he offend the gods somehow or offend our deepest moral principles if there were a sucker out there who would pay him $2 million for his kidney, which is probably not in that great shape. Hard to imagine, and we could give other similar examples. And we know that men sell sperm samples, and Harvard girls sell their eggs for five-figure sums, and so on. All of these involve commodification of body parts. There doesn't seem to be anything terribly wrong with it, although some practices are probably bad. All right, so that may not be convincing. Okay, variation number two. It's not commodification; it's exploitation. Well, obviously, it's exploitation in the sense that the richer person is taking advantage of the necessity of the poorer person. That's built in. The question is it wrong? Is it wrongful exploitation? Every time we buy anything these days, it's made by somebody in China who wouldn't have made it if they'd had more money and didn't have to take that job. So all of us, whatever we're wearing and carrying, involved exploitation. Now, some people think that that's wrong. Others think it's not wrong. It's just a result of differing levels of economic development. But it can't be the shocking affront to basic principles that would warrant a ban on this practice if it's nothing more than the same thing that happens when tennis balls and scarves are made in a poor country. Now this is, I don't mean to demean this argument because I think there is something to it, but it's one that has to be made more vigorously and seriously than it has been. Now here's the third variation, and this is one that seems to me, if there's a right answer, this is it. And I'm saying that as a hunch because I can't really make good on this, but I'd like to be able to. The third argument is that we should focus less on the individual abuse, less on the transaction between one seller and one buyer, which may very well be advantageous to both. Instead, we should look at the social order we're creating if we allow this kind of trade. Now, imagine you have a country where it's perfectly legal for the poor to give up organs, and the price is high enough so that many of the poor see that it's an obvious choice that they should make. What have we got? We have a society now where a mother can be talking to her young son and say that you will not go to the grave with your body intact. You will have sold, by the time you get to be a middle-aged person, you will have sold off all the parts of your body that there's a market for. But only the poor will face this future. It'll be a kind of a caste, the caste of organ sellers. And these people in society will be marked permanently because you can get the organ back. It's not like selling blood, which is a renewable body part. In this case, it's a permanent mark on you that says you're one of those. Some work by our colleagues at the Harvard Law School on the uninsured in America found the very surprising result that if you ask these people what would be your highest priority if you could afford health services, the highest priority was dentistry. The reason being that many of them lacked one or more front teeth, which is a horribly stigmatizing condition. So they had learned to put their tongue, their lip, it's hard for me to lecture while I do this, they put their lip over their teeth when they smile, which gives you a pretty weird smile. And also everybody knows what they're doing, and they knew it. But why did they go to those lengths? Because they don't want to show the gap, because that means that they're a person too poor to go to a dentist to get that fixed. And they just can't stand it. So imagine that we had a caste here of people who are scarred here and so on. Let's take this a step further. Suppose that we decide that there's really nothing wrong with this. We just have to brace ourselves and get used to it. Well, let's not step a kid these. Let's go to eyes, because you can do okay with just one. So people who are lacking in vision altogether, or maybe who have a bad, poor vision in one, don't want to wear glasses, whatever. They make a deal, and a poor person sells them one of their eyes. So we have a cast of people who walk around, with this empty socket here. I think there was a movie like this recently. That would mark them out as, a special kind, a special type within society, and undoubtedly be a terrible burden to carry around as a stigma. So I think the strongest argument is going to be something of this sort, that we don't want to create a caste like that. But let me not pursue it anymore. Suppose that none of these arguments work. Suppose that none of them are convincing. Two possibilities. One is that our aversion to selling body parts is merely a form of intuitive distaste. Now, where I grew up, in Kentucky, a man and a woman holding hands on the street were enough to make people vomit if one of them was white and one of them was black. So I know from repugnance that was real repugnance. Fortunately, we've sort of gotten past that. If that's all this is this intuitive distaste that we can't give any good reasons for, that's not very powerful, not a very good argument. Certainly not enough to base a ban on. Second possibility is that what's really going on with the people who want to ban organ sales, and maybe even with prostitution to some extent, is that these are vivid emblems or forms or consequences of an underlying evil, which is horrible inequality and the existence of chronic deprivation. What we're really upset about is the deprivation and the inequality. It's not the practice, really. It's the practice makes it unavoidable. You can't not look at it. And the thing about it is that once you've got the inequality, according to people who want to argue this way, the selling makes things better, not worse, because it lessens the deprivation and inequality just a little bit. Now, that's a null hypothesis. Basically says that there's nothing inherently wrong with the selling except for the inequality that motivates it. And actually, since it ameliorates the inequality a bit, it actually is not, that's not the wrong. Now, I said earlier that given that lives are at stake, you have to have a really good argument to want to ban. So those of us who think about this and who share Luke's and Frank's strong feelings that an unregulated, especially an unregulated, but almost any kind of market for organs is a social wrong that we should try vigorously to oppose. And I have to say my feelings are perfectly in alignment with theirs. We need to think even harder than we have.
Thank you. I'm going to take the liberty of saying that we're going to go 10 minutes over because this is just lots of rich conversation. So it's my privilege to move on to Dr. Frank Delmonico and those of us from MGH. To those, he doesn't need any introduction. He's really been an esteemed professor at MGH for quite some time, world-renowned, really for his extraordinary and relentless effort on behalf of vulnerable people in the world. He's been a transplant surgeon for many, many years, and I get emails, and we all do, from the most unusual places on earth, as he's really protecting those who need him at their side. And he's taken a leadership position in the world, specifically around this particular topic.
Thanks, Tom. It's very kind. So, what I'd like to do for some moments here is to give some understanding about the Istanbul Declaration, but as well to, I hope, give some description, the vivid reality of the social disorder that we've encountered by organ trafficking, transplant tourism, as we've gone around the world in these consultation processes, to see, as I say, the reality of these practices. And once you experience that reality, you're confronted with the options that you've heard about from Dan, and you, I think, naturally reach the conclusion that these practices are not those that can be sustained. Istanbul came about as a result of the World Health Assembly saying to member states, you have to address transplant tourism and trafficking. It urged member states to protect the poor and the vulnerable that were in the midst of these trafficking tourism practices. One objective in bringing transplant professionals from all over the world to Istanbul was to define trafficking, tourism, commercialism, and not to only say no or an objection to this, but to bring alternatives. It's essential for us to say there has to be another way in providing for those who are in need of organs. And I do wish to address that, even just briefly. We already talked about trafficking, the exploitation of the vulnerable. It is indeed that. Let me expand, however, on the transplant tourism piece, which hasn't been brought to your attention. Tourism is just not travel for transplantation. Tourism involves, as Luke pointed out, client and destination countries. But here's how it has its impact. The client country says, we can go to a destination and we can have the poor of that country be our stockpile of organs. And that becomes the reality. It becomes the reality if patients from a Middle East country regularly go to Manila to have the poor, the slum victims be the source of organs by insurance companies that foster the transplants in that location because it's cheaper and because there's a readily available source of organs for them in effect to fill. So the rich country, client countries, send their patients preferentially to those economies where in India, Pakistan, Philippines, organs can be readily available for these patients. It's always the poor that are involved in these sales. It becomes the rich patients that have the wherewithal to travel, and insurance companies foster that practice. They enable it. And the transplant professionals in both countries are doing that as well. Transplant professionals in Manila certainly are compensated well for all of the transplants that they then do as a result of that practice. And there may be, in the client country, compensation considerations to preferentially send the patients there to begin with, to have those transplants performed. What happens as a result of transplant tourism? If you can go to a country and obtain those organs, then there's no need in the client country to have a practice of organ donation and a self-sufficiency. You can simply rely on the poor country's population to be the source of organs. And you say, well, that gets a bit extreme. No, I only hope that as this afternoon, I can be convincing of you that in a global economy, if we are allowing sales, we are setting up a market in which we will have the poorer country be the destination source. And as a result, in the rich country, they see this as enabled and an economic feature of we'll just go to Manila, we'll just go to Lahore, Pakistan, and we'll be able to buy our organs. And it's not either a matter of black markets. It becomes all on the surface. There's no obstruction to it, there's no impediment to it. And these practices then become ingrained in the transplantation experience of a country from the Middle East, or from the United States, or from Canada. In this transplant tourism piece and trafficking, Mary mentioned about how can that entail deceased persons, the trafficking. The reason, Mary, we went there was because of China. It's an exploitation of the vulnerable who are slated for an execution to say to them, you are now going to part with your organs as well. And beyond that, when you have a system set up in which executed prisoners are used preferentially or as an organ source, we all became very well aware of instances in which we could know about a scheduled transplant next Tuesday of a B blood type liver. So that as a patient goes to a site in mainland China, Tianjin, China, Guangzhou, China, there's an expectation that this patient will be able to undergo a liver transplantation within a very immediate time frame. One then wonders whether or not the need for organs is fueling the need for the execution. So that in this system of it's the executed prisoner as the source, next week we've got, as a result of Egyptians who are regularly going to China for their livers, we'll have so many patients that are in need, that means we have need for so many executions. And when you have 5,000 executions that are the source of organs of about 12,000 transplants, 8,000 kidneys, 3,000 livers, one can only wonder about this. So there's no transparency factor that we can have CNN cameras go in and find out how compliant the individual might have been to say, I'm all right to be executed next Tuesday so that I can have my liver given to that American person who's coming or someone from the Middle East, etc. So organ trafficking and the exploitation of the vulnerable was intended to address this issue as well. Transplant tourism not only disadvantages, in terms of the client country, the opportunities of developing a national self-sufficiency, it also disadvantages the individuals in the destination country. If in South America there is a country that is soliciting by websites individuals to come there for their transplants, what of those who are in need of transplants within that country that may not have the resources that are available to those patients that are going there? And what then if there's a preferential transplant done for the individuals that are coming from the client country, systematically, with hotel reservations and scheduled transplants under circumstances that say, now the resources of that country are being directed, targeted to client country patients that are coming there preferentially to undergo transplantation. So we witnessed then the disadvantaging of patients within a particular country as a result of transplant tourism, when they themselves are unable to have access to transplantation practice and care because those who can perform the transplants and the organ sources that might have been available for them are now being made available for the rich country patients that are coming there for the transplants. Mary mentioned transplant commercialism. By definition, it was made as a commodification of the organ, the fact that the organ would be the object of the sale. And the question arises whether or not commercialism always involves exploitation. In a global market, in this global economy, the reality is that it does. Mary mentioned about the violations of the victims of trafficking, the victims of trafficking being those with economic deprivation and crisis situations. The Iranian model has been touted as a model of organ sales that are so-called regulated. Well, it's the government that sponsors the sale. But now recent data that has been forthcoming is as what Dan was talking about. When one starts to examine the vendors, those that are selling, the clinical profile of those individuals becomes very similar. They are indeed those that are deprived, extremely poor, in crisis situations, have no job, lost a job. All of these data now are forthcoming, even about Iran. And when one says that there's a regulated market and considers that there would be fixed price or governmental oversight, the Iranian model becomes the example of how that can't be accomplished. That experiment now has been tried there, and there is no such thing as a fixed price. There are brokers that naturally enter into the transaction. And it is indeed those who are very well deprived economically. It is not then a matter of their choice. If they have no way to feed their family, that isn't a matter of autonomy. That is a compelling circumstance in which the individual is victimized. Who becomes the seller? All of this is the reality for us that we were confronting in Istanbul. And the transplant community now, as I say, is not just saying no. It wishes to create alternatives, to bring deceased donation to every country, which has not been maximized, even in this country, and to provide care for those who wish to be donors, those who will be live donors. There is an inadequate care that is provided for those individuals as well. Istanbul calls upon the transplant community to care for the individuals who are live donors. This is a two-pronged attack.